Hi everyone, welcome to Unheard Voices in Obstetrics and Gynaecology. This is a conference that is a collaboration between the British Undergraduate Society of Obstetrics and Gynaecology and the Nottingham Obs and Gynae Society. My name's Molly, I'm a third year medical student at Nottingham. I'm one of the incoming events and finance officers for the BUSOG, and I am president of the Nottingham Obs and Gynae Society.
Hello, thank you all for coming. My name is Katrina, and I'm also the incoming events and finance coordinator of BUSOG together with Molly. So I am a medical student at Queen's University Belfast. I've integrated this year in a Master's of Experimental Medicine, and I'll be joining fourth year in August, and I'm also from Latvia.
Hello everyone, thank you so much again for joining us on a Saturday. My name is Jhia Teh and I'm the outgoing events coordinator for BUSOG. I'm currently a foundation year 2 doctor in Torbay Hospital, and I will be starting my obstetrics and gynaecology training in Wessex this October.
Perfect. So firstly, I'd like to thank all of our speakers for joining us, my BUSOG colleagues Jhia Teh and Katrina, and to the Obs and Gynae Society events officer at Nottingham, Nihar, and the rest of the committee. I first pitched this conference idea to Jhia Teh just before Christmas, and it was meant to happen around April, but obviously COVID-19 happened, which meant that we had to kind of rethink how we were going to do it. We hope that using digital platforms is something we can take into the future to make the BUSOG as accessible as possible, although we would obviously still love to do some in-person events when we can. Access and inclusivity is a topic we want to be the basis of a number of our events during our 2-year tenure at the BUSOG. Obs and Gynae, along with a few other specialties like general practice, is unique in that most women will engage with it at some point in their lives. Obs and Gynae deals with conditions which are often deemed as private or taboo, as well as pregnancy, which for some is the greatest time, but for others is shadowed with fear and anxiety. Feelings and embarrassment, shame, fear, and mistrust can be seen commonly in patients, and the ability to provide accessible and inclusive care is of the utmost importance to ensure all of our patients, no matter who they are, feel comfortable, understood, and safe enough to engage with us, ask questions, and sometimes come forward with the darker struggles they may face in their lives. Doctors, nurses, midwives, and other healthcare professionals hold a significant amount of power. You are or will be there for some of the darkest and most terrifying events in people's lives, and they and the system put a huge amount of trust in us. This is a privilege, and one that has often been abused. This abuse includes conscious acts, but can also include unconscious acts, such as those which result from not educating yourself about and addressing the unconscious biases you hold and how they will affect your patients. It is important for us all to recognise any holes in our knowledge and any unconscious biases we hold, and listen to clinical, academic and patient experts in order to adjust our thinking and practice to be of the high quality that is required of us to deliver safe and good care. Women have historically been silenced by medicine, with groups such as people who are Black, Asian, or from other ethnic minority backgrounds, members of the LGBTQIA+ group, and those from lower income backgrounds being especially negatively affected by unconscious bias, lack of communication, and prejudice. Statistics such as Black women being 5 times more likely to die in pregnancy in the UK place an unforgivable and highly disturbing mark on the profession, and I hope that the future and current generations in medicine will do the extensive personal, academic and clinical work required to improve outcomes for everyone. We want to talk about these topics openly with experts who have dedicated their careers to improving outcomes in Obs and Gynae in order to help best prepare our members for providing the highest standard and quality of care. This conference will provide information on a variety of topics, including homelessness, trafficking, FGM, domestic and sexual violence, and abortion care. It is by no means comprehensive, but we hope that it will be a good introduction to what we endeavour to do over the next 2 years. If anyone has any suggestions for future events, please email email us on busogevents@gmail.com. Thank you very much, and I hope you enjoy the day ahead.
I would just like to go through the programme and the logistics of how today will work. We have 4 talks today. Each will be 30 minutes long with 15 minutes for questions. And there will be a 5 minutes break between each talk and a lunch break from 12:50 to 1:30. We will be live streaming the entire event to the event page, and you can watch the saved video later as well. I also wanted to mention that it's been highlighted to us that someone has been commenting on our posts with some links. So please don't click on any of these links, as we can't guarantee that they are safe. We will be using a website called Slido for questions today. A code has been posted by one of my colleagues for each talk. You simply go onto sli.do and type in the event code for the speaker you would like to ask a question to. You can also upvote the questions you want answered the most by clicking the thumbs up button next to the question. Please use this website instead of the comment section on Facebook. We hope to follow the schedule as punctually as possible, but please bear with us for any technical issues we might have, as this is our first virtual conference.
So just before we open the floor to our first speaker, I want to take a moment to discuss some of the sensitive content we'll have in our conference today. So we want this day to be a positive experience for you all. And we really hope that you'll go away having learned something, and that will make your future practice even better, and help you better understand the populations that are less talked about in obstetrics and gynecology. However, we do recognize that some of the topics covered today will be sensitive, and it might be triggering for some people. So we do urge you to prioritize your mental health, and it is of utmost importance to us as well. So if you feel uncomfortable or unable to cope at any time, we want to make sure that you know where to turn. So for this reason, we have provided some contact details of some helplines, and also our own contact details in the event description and as a post in discussion. So please do take care and contact us or these helplines if you feel uncomfortable at any time. So with that in mind, we'll open the floor to our first speaker. So thank you all again very much for coming, and I hope you enjoy the day.
So I'd like to go ahead and introduce our first talk for the day, which is Pregnancy, Women's Health and Homelessness. And this talk will be given by Catherine Glew. Catherine is the Women's Strategy Manager for St Mungo's Community Housing Association, a charity that helps homeless people. In her talk, Catherine will discuss the issues faced by women sleeping rough and in homelessness services, and the impact of homelessness on women's experiences of pregnancy and maternity care. She will also introduce listeners to some resources and support available for homeless women, and introduce the St Mungo's No Going Back campaign, which calls for safe and secure housing for women. Now going to pass it on to Catherine.
Thanks so much, Jhia Teh, and thank you very much to Molly and Katrina as well for inviting me today to such a well-organised virtual conference. I'm excited for you on your first virtual event, and hopefully it's the first of many. So yes, my name's Catherine. I'm the Women's Strategy Manager at St Mungo's, and I'm going to attempt to share some slides with you. Let's see. I'm hoping that you can now see some PowerPoint slides just to kick off my talk. So to introduce you to St Mungo's, as Jhia Teh said, we are a homelessness charity and a housing association that operates in London and across the south of England, providing housing and support for people who are homeless or at risk of homelessness. Now, the kind of support we provide is very varied. We have over 300 different projects that we provide across the geographical areas where we work. And that ranges from hostels, supported housing, outreach services for people sleeping rough, specialist employment support and health support, and a range of other projects and initiatives that meet the needs of people who are experiencing homelessness. So we're a very large and diverse organisation. And my role as Women's Strategy Manager is to understand the experiences of our female clients in particular, having in mind that women's homelessness is quite different to men's homelessness, both in its causes, the experiences that women have while they're homeless, and also the routes out of homelessness for women. So in 2019, in March 2019, we published a 3-year women's strategy, which challenges our organisation to improve our services for women. The homelessness sector in the past has been quite male dominated, and quite often homelessness services are majority male, and that's very challenging for women who are trying to access those services to move off the streets or out of homelessness and to find recovery. So our strategy includes a number of projects designed to improve our response to women's homelessness and to understand more about our clients' experiences. And that's a 3-year strategy that we just finished the first year of. So today I'm going to talk a little bit about what life is like for homeless women. I suppose to give you some context for how any patients you may see may be experiencing life during their pregnancy. And I'll, as Jhia Teh mentioned, signpost you towards some resources that can be useful for any patients and also yourselves as professionals to learn more. I should say to begin with that the primary group of people that St Mungo's works with is what's known as single homeless people. And that just refers to people who don't have a family with them. So quite a number of our clients do have children and may well have partners and be in relationships. So single homeless is a little bit of a misnomer. But it just means people who don't have children in their care, which means they have different entitlements under housing law. So they're more likely to not be in priority need for housing from local authorities, so therefore more likely to end up sleeping rough or in hostels. So single homeless people, but so if you hear me use that term, it doesn't necessarily mean that people aren't in relationships or don't have children. That's just kind of the homelessness sector term for the clients that we're dealing with. So to start off with a bit of background for you around life for homeless women. So around a third of St Mungo's supported housing clients are women. So that's women living in hostels, semi-independent projects with some level of support on site. So around a third in accommodation, but around 14% of people sleeping rough in England are women. I should say that that's 14% of people recorded sleeping rough. And there are indications through research and through the evidence that our outreach teams see that women are likely to be missed out from those statistics. So the 14% may be an underestimate, but that's the official statistics that we have from government. So 614 women slept rough on any one night in autumn 2019 across England. Life for homeless women and anyone sleeping rough in general is extremely harsh, very dangerous, and very poor health outcomes associated with rough sleeping and any experience of homelessness. So you can see there ONS statistics. The average age of death for a woman who dies while homeless is 42 years old. And that's a result of all sorts of negative health impacts of homelessness that really have a grave impact on people's quality of life and their health. So we tend to support women and men with a variety of very complex needs. Quite often our clients have faced multiple disadvantages in their life from childhood onwards. So of women living in our supported housing during 2017-2018, these stats were compiled for our women's strategy that we published last year. 8 in 10 of women need support for their mental health, and that's higher than for men by about 10%. And around half of women need support with substance use, commonly crack cocaine use, heroin, and sometimes alcohol as well. That's slightly more common for male clients. The high risk of overdose among female clients, about 46% of clients who were women were seen by workers to be at high risk of overdose from drug use. Around half our clients are in fact mothers, so it's very common for our clients to have had children in the past before they come into our services, and then unfortunately have had those children removed from their care. They may be in the care of friends or family members, or they may be in local authority care or have been adopted. And I'll speak more about that later, but that can be carry a huge sense of shame, grief, anger sometimes, that women tend to be carrying forward when they are trying to work towards recovery. The sort of sadness that they feel from having lost contact with their children can be a huge barrier to women moving on with their lives. And finally, the statistic there, 35% of our female clients are lonely or isolated, and I think that's very important. Relationships are extremely important for any of our clients, but for women in particular, we find that a relationship-based approach to recovery, so building up trusting relationships with staff or with other clients, their peers, is really fundamental to women moving on from homelessness. And quite often that can be a long process and something that takes a lot of time. So when you're working with any woman who's experienced homelessness or any client who's experiencing multiple disadvantages in your life, we found that you can expect trust to be difficult for that person. Quite often they will have been let down a lot in their life, and it may take perseverance and kindness and care from support workers or medical professionals to build up a trusting relationship with women. Sadly, also the experience of violence and abuse, either from partners or family members, is extremely common for women who've been homeless. Quite often that's experienced both in childhood and in adulthood. Some research we conducted with the University of York back in 2018 found that experience of violence and abuse was near universal for women who find themselves homeless. So I think it'll be fair to say that if you come across a woman who has that homelessness in her past, she's also likely to have experienced some form of intimate partner violence or abuse or family violence. So the consequence of this, the sort of trauma that women have experienced and their lack of trust, does mean that women tend to be more hidden while they're homeless. So that looks like one of two things usually. Either it's that women will do everything in their power to avoid sleeping rough because of the huge amounts of risks to their safety when they are on the street. So women quite often will rely on family and friends for long periods of time, sofa surfing, that more hidden homeless situation to try and avoid sleeping rough. And when women do end up on the streets, they will tend to be more hidden. They may sleep, away from public areas. So they might be in parks or in bin chutes, in areas where they're less likely to be found. And that is a choice that women make that is absolutely understandable, because life on the streets for anybody is extremely dangerous, and the risk of sexual violence and physical violence for women is very high. However, what that does is it tends to hide women from help as well. So while women may be making a choice to try and keep themselves from harm, it means that services can't always reach them, and it may take longer for them to find the support they need. Women also tell us that they avoid services where men are present, and unfortunately at the moment in England, the vast majority of homelessness services are mixed gender, so they include both men and women. You'll see there that only 10% of homelessness accommodation projects in England offer women-only support, according to Homeless Link data, and 60% of English local authority areas have no homelessness services specifically for women. So in that context, female clients are likely to avoid services because there's nothing for them that's specific for women. I wanted to share with you some quotes and some stories that women have told us in the course of some of the research we've carried out over the years, because I think that will give you a really personal view of how it is to be homeless as a woman and some of the experiences our clients face on a daily basis, unfortunately. So these quotes are from research we conducted with the University of York that I mentioned, and they were all women with experience of rough sleeping. So they were women currently living in homelessness services, so hostels or shared housing, but they'd had experience of rough sleeping in the past. And you can see there that women feel very strongly this threat of violence and abuse while they're living on the street. So she says, we have to hide, because if we don't, we're going to get raped, kicked, or beat. Women also feel as though services won't believe them if they come forward about the violence and abuse they're experiencing. And quite often that is not an unfounded belief. Sadly, many women find that when they disclose violence or abuse to police or to services, perhaps that's not taken seriously, or they're not able to access the support they need. And I know a later speaker at the conference will be talking more about domestic abuse and sexual violence. So our client says it's like you're in a different world when you're in a domestically abusive relationship. Nobody believes you. And then finally there, a client talks about the disconnect she feels between her previous life before rough sleeping and the situation she finds herself on the street. So she says, I've always been with my family, a family person. I've never been out there, and all of a sudden to be chucked out there like this is your life, I didn't know what to do. So women can feel a real sense of disconnect from the expectations that society has around women being family people, you know, homemakers, caretakers. And I think women experience a lot of stigma directly while they're sleeping rough, but also have a sense of self-stigma perhaps, that the identity they held before they became homeless has been broken because of the situation they find themselves in on the street. So with that context in mind, here are some of the things that our clients talk about when they experience pregnancy. So we do support pregnant women, both on the street and also in our hostels and supported housing. So pregnancy is relatively uncommon for street homeless women, but it does happen. I was told just this week by a colleague about a woman sleeping rough at the moment during COVID-19, who is in her third trimester and had accessed absolutely no maternity care up to this point. She's a Romanian national sleeping rough with her partner, and apparently this is her 11th pregnancy. So it does happen, though it is relatively rare. But if pregnant women are sleeping rough, it's very, very likely that they won't have accessed maternity care and may be experiencing complications and health issues related to their pregnancy. Women in our services, so in our hostels, may well become pregnant, even in women-only services. So, you know, we understand that our clients are adults and have adult relationships and may well have partners outside the service, or if there are mixed services, may form couples or relationships within our services. And while we'll always try and support our clients to make informed decisions about their fertility and about the future of their pregnancy, women will become pregnant, and that can sometimes be a real sign of hope for the future for them. Quite often when women have had children removed from their care in the past, pregnancy can be something they desperately want, and it's not uncommon for women to experience repeated pregnancies, especially when children have been removed subsequently from that. So we may see that women seek to become pregnant out of a sense of loss or grief that previous children have been removed. And that's something we work with women on, but it's a very, very difficult emotional journey for women to deal with when they become pregnant again following the loss of a previous child. So it's a sense of hope for the future, but we do have to support our women to be realistic about their options. Quite often, if women are still in the early stages of their recovery from homelessness, there may be issues in their life that mean it would be unlikely that they'll be able to keep the child in their care. And we have to support women to understand that and consider, you know, the practical options that are available to them if they want to go through with a pregnancy. If women do go through with their pregnancy, it can be a time of real trauma. Unfortunately, some women do become pregnant as a result of sexual violence, and that's something that requires a lot of specialist emotional support that St Mungo's, as a sort of general homelessness provider, isn't always equipped to provide. So we'll always look to involve specialist services for women, specialist sexual violence services in the emotional support that women need when that happens. Trauma that women feel through their pregnancy, as I said, can come from previous loss of children, the grief and shame that comes with that. And also, I think experience of trauma can also impact women's experiences of maternity care as well. So women may have a very, very hard time being examined, you know, being touched. If they've been subject to sexual violence in the past, any kind of examination can be extremely stressful and traumatic, and that can lead women to avoid maternity services when they need them most. I should also say that risk from domestic abuse is very, very high during pregnancy. It's a time where domestic abuse can start or escalate within a relationship. So we're always mindful that pregnancy can be an indicator that a woman is at higher risk from serious harm or even death from domestic abuse. In terms of outcomes for the pregnancy, some of our women, especially street homeless women, will have extremely poor nutrition, and that obviously can have health impacts for themselves and for their pregnancy. And drug and alcohol use as well can have complicated implications for their health outcomes. Now, I'm not an expert on this by any means, but I will point you towards some resources towards the end of my presentation that you might like to read and understand more about those specific issues. Mental health, as mentioned earlier, a very high proportion of our female clients need support for their mental health in general times. In pregnancy and also after birth can be times where mental health, people's mental health needs can increase and they'll need additional support. I'm jumping a little bit ahead of that list, but I wanted to mention that quite often if a child is removed from a woman at birth, unfortunately, the support that surrounded that woman during her pregnancy can be quite abruptly removed, leaving that woman quite isolated, and that particularly can be an extremely challenging time for a woman's mental health. So say if a woman's been pregnant in services, she may go ahead and have that child, the child may be removed, and then she'll have to return back to homelessness services without her child and be sort of subject to questions from other clients, and just be left with that sense of loneliness and loss, struggling on her own, where all the support that surrounded her during the pregnancy is removed quite suddenly. It can be a really difficult time. For our clients who are non-UK nationals, who have various different immigration statuses, access to maternity care can be a really, really fraught issue, and there are genuine issues around NHS charging. And again, I'll signpost you to some information about that. But there's also, I think, a large degree of fear for women, especially women who are rough sleeping, that if they access maternity services, that they will be asked about their immigration status and they may be subject to immigration enforcement as a result of that. So that may mean that some women present very, very late in their pregnancy, or sometimes not at all, for maternity care because of that fear. And what I would say is that if you're unsure about whether a patient that you're seeing is being charged correctly or receiving the correct assessment of their immigration status, there are resources you can look at to try and determine that, and advice you can seek, which I'll let you know about later in the presentation. Obviously, our priority at St Mungo's is always safeguarding children as well as adults. So where a client does become pregnant in our services, we will, if we need to, involve the relevant child safeguarding authorities, as well as raise adult safeguarding alerts when we need to. But we're always mindful that that can be an extremely distressing process for women, and we'll always try and involve clients in that process to help them understand what's likely to happen when we make those safeguarding referrals, so they can be fully informed and try not to exacerbate the trauma they may be experiencing. Women's housing options do change, and their entitlements to housing under the legislation do change when they become pregnant. So pregnant women and women with children are entitled, they're in priority need for housing by a local authority, which many of our single clients are not. So pregnancy may actually result in a woman having different or sometimes better housing options than were available to her before she became pregnant. Unfortunately, we do find that that doesn't tend to kick in until quite late in the pregnancy. So we have had cases where women are 7-8 months pregnant and are still told you're not eligible for housing assistance until you're very, very late in the pregnancy, or even until you've given birth. So while it might seem that pregnancy can be an opportunity to improve someone's housing situation, that can also be quite complicated and will vary by local area. So it's really important that women are supported to approach their local authority, knowing their entitlements, and to understand what their options are and when they're getting the best possible deal for them. Let me take a look at the time. Okay, all right. So here's a quote from one of our clients who took part in some 2014 research, which just shows, I suppose, some of the situations that our women find themselves in. So she says, "I don't get on with my mum, but she's looking after my 7-year-old, you see. My child is my motivation for getting clean. It feels like not having enough food. I'm hungry for my family, starving for them, and I won't be full up until I've got them back. It doesn't happen overnight, and you need the right help, but I'm getting there." So I suppose I wanted to include this because it shows that though homeless women can be experiencing all sorts of terrible issues while they're pregnant, it can also be a time of hope and motivation for recovery. And quite often when we support women to reconnect with their children, where that's possible and safe, that can be an amazing moment for them. So I wanted to mention that because there's a risk sometimes when you're working with homeless women that everything seems like a risk or a danger. And actually sometimes taking a positive view of what's happening for that woman, helping to understand her rights and entitlements and what she can achieve and her strengths, can be a really powerful tool to help someone improve their life. So here are some resources and guidance I wanted to let you know about. First of all, and I can't take any credit for this at all, we have an amazing pregnancy toolkit at St Mungo's, which was put together by a colleague of mine who's now left the organisation. And what that does is set out many of the issues that I've touched on today in a lot more detail, with a lot more expertise than I have myself, and just gives signposting to different services and advice. It's designed for homelessness settings, so for workers in services such as ours, but I think it will be really, really useful for anyone in the healthcare field who's working with a woman experiencing homelessness, just to look at and understand and be more aware of the issues that some of our clients face. So do take a look at that. It's on our website. I've put the link in there, but I'm also more than happy to share these slides with participants if that's helpful for you. And I also wanted to let you know about some external sources of support beyond what St Mungo's can provide. So My Body Back is an initiative that provides maternity clinics, and it provides cervical screening for survivors of sexual violence. So what they do is they try to understand the trauma that people can experience when they're going through pregnancy or any kind of obs and gynae issue, I guess, any kind of examination that someone might have that might be very distressing for them because it might trigger memories of their sexual assault. And they've designed specific clinics in order to cater for that group of clients. So healthcare professionals can refer to those clinics. Unfortunately, at the moment, they're on hold due to COVID, but I would encourage you to visit that website and take a look at their work, because I think it's really unique approach. They are based in a hospital in Mile End, but it is a service for clients across England, so anyone from across England can be referred. And it's also inclusive of trans men as well. The Pause Project. Now, the Pause Project works with women who experience repeat pregnancy and quite often have those children taken out of their care. So they work with women, it's an extended period of time. They provide specialist casework to support that client to, I guess, pause, as the name suggests. So they provide long-acting reversible contraception to clients and then provide them with emotional and practical support to help them plan their lives and then take control of their fertility when they've experienced that cycle of repeat pregnancies, which is not uncommon for women who are homeless. They operate in various different areas across the country. They're not national, but it's worth looking at the website and seeing if there's a Pause project operating in your area that you might be able to get in contact with or share knowledge and expertise with. And then I've mentioned the Maternity Care Access Advice Service there. So if you're unsure if a patient's being correctly charged for NHS care due to their immigration status, then you can contact the advice service. They've got a phone line and an email advice service as well. So to help patients understand their entitlements and kind of reassure patients as to what they can expect during their maternity care in terms of charging and entitlements. As I said, that's a real source of fear and anxiety for a lot of women who have unresolved immigration issues. And then finally, this is less specific to pregnancy, but the Faculty for Homelessness and Inclusion Health is an inclusive membership organisation hosted by Pathway, which is a homeless health charity. And they've got excellent resources for healthcare professionals who are working with homeless patients, patients selling sex, Gypsy, Roma and Traveller patients. So they've got a really great set of standards which set out what services can best provide, the kind of best practice for services working with those groups, which are available on their website. I've put in the link there. They've also got, and I haven't touched on this in much detail today, but they've also got some really great guidance on healthcare professionals' duties under the Homelessness Reduction Act, which is a piece of legislation introduced in 2017, which aims to, prevent and reduce homelessness before it starts. And one of the duties in there is for healthcare professionals to refer any patients they know or suspect are homeless or are sleeping to the local housing authority. And there's detail about what that means and the process for that in that guidance from the Faculty from Homelessness and Inclusion Health. am I doing for time? Okay. All right, just to finish up, so how you can help. There's a couple of things here that I really encourage you to look at and get involved with if you're interested in women's homeless health or homelessness in general. So as was mentioned at the beginning, St Mungo's has recently launched our No Going Back campaign, and that's in response to the massive effort that's been put in by local councils, homelessness charities, to house people who were rough sleeping before the COVID pandemic. So many people who were sleeping rough. There's vast effort over a period of about 2 weeks at the beginning of lockdown to bring people into hotel accommodation so they could safely self-isolate. So we now have thousands of people staying in hotels across England, which is a fantastic achievement and just shows that with some funding and political will, rough sleeping is a problem that can be tackled quickly. However, the future is quite uncertain for those people at the moment, and we're not yet sure whether permanent accommodation and support will be made available for all of those clients. So we're campaigning, we're asking people to write to their MPs to ensure that no one has to go back to the streets after the lockdown period ends. And as part of that, we're campaigning for specific safe housing and support for women and survivors of domestic abuse. I highlighted earlier the low levels of women-only accommodation available for homeless women across England. We think that needs to change, and we think that every woman should have the choice to access women-only homelessness services if that's what she needs. So I've included the link there. If you want to write to your MP, that would be greatly appreciated. We really love your support. And finally, if you're concerned about someone you see sleeping rough, that's during the pandemic or at any time, you can contact StreetLink, which is a partnership between St Mungo's and Homeless Link, and that's a referral service. So you will make a referral, giving a few details about the person you've seen sleeping rough, and then those details will be passed on to the local service, which will contact that person and offer them support. So it's not an emergency helpline. You can't expect someone to sort of turn up within minutes or hours, unfortunately. But what it does is it gives information for local outreach services so they know where people are and they can efficiently find them when they go out on shift. So StreetLink has a website, which I've popped there on the slide. There's also a phone line, which you'll find on their website as well, and an app as well. So yeah, download that to your phone, and if you see anyone sleeping rough, do make a StreetLink referral because it really makes a difference. And I think that's it from me. So thanks very much for listening, and yeah, I'm absolutely happy to answer any questions anyone's got. Thanks very much.
Thank you very much, Catherine, for that very insightful and informative talk. We have had quite a few questions come through, so I'm going to ask you the questions as they've been in the priority that they've been upvoted. So starting with the first question, are there any projects which cater specifically for transgender people who are homeless?
Yes, there are, yeah. So St Mungo's actually has an LGBTQ pathway in East London, and that includes a house that's specifically for trans clients. What I would say is all our women's services are trans inclusive, so we recognise that trans women are women and will be accessing our women's services. That's part of our understanding, I guess, of the complex needs that all our female clients have. We quite often work with women who are multiply excluded from other services who can't access, for example, mainstream domestic abuse services because of their drug and alcohol needs or their mental health needs. So we recognise that most of our clients are multiply excluded, including our trans clients. But yes, in terms of specific services, there's our LGBT pathway in London, which is pan-London. So any client who's London-based can be referred to that accommodation service. There's also, at the moment, so the Outside project, I'd encourage you to take a look at. They're an LGBT homelessness shelter, and they currently have accommodation during COVID-19, and they do usually run a day drop-in service, I think. So the nature of that's changed during the pandemic. But the Outside project, I'd recommend you look at them as well, because they are, they're trans inclusive and very knowledgeable about LGBT homelessness in general.
Okay, that's great. Thank you. Our next question is from Harry. What would your top piece of advice for medical professionals when engaging with women who have experienced homelessness?
I think expect the unexpected. I think quite often it's really, I understand it's very, very difficult within the constraints of NHS services, but the more time you can give that woman and the more space you can give for her to speak, even if the way she speaks is confrontational or might be challenging, difficult to deal with, difficult to hold as a professional. I think hearing that, letting her speak and helping her know that she's being listened to and trusted is more important than anything, really. I think so many women who've been homeless will have been ignored by services or, not believed. So I think, listening and believing women would be my top piece of advice, definitely.
That's really good advice. So our next question is anonymous. How difficult is period poverty affecting homeless women in the UK?
Period poverty, was that?
Yeah.
Yeah, absolutely, it's an issue. There've been lots more initiatives set up in the past few years around period poverty, which is excellent. Certainly it affects our women. I think for rough sleeping women, it's a particular issue, and I think it can lead to all sorts of health complications. Honestly, you have women using sanitary products for much longer than is advisable, or not being able to access them at all. Access to public toilets is a huge issue, particularly at the moment. I do worry about that actually, because many public facilities are closed. And though I mentioned that many homeless people have been brought into hotels during COVID, there is a growing number of people sleeping rough who are who've become homeless during the pandemic and are out there. And at the moment, the lack of public facilities must be a huge problem. So yeah, it is an issue in our services. To be honest, sexual health isn't something that the homelessness sector has been great at talking about. I think because, as you mentioned at the beginning, Jhia Teh, the stigma around relationships, sex, women's health, these things definitely translate across to homelessness services. And I think a lot of our staff rather feel quite unskilled, like they don't quite know how to address it. They don't quite know how to have the conversation. So yeah, that's been a barrier, I think, to us addressing period poverty, if I'm being honest. But what we have done recently is we've published a new couples and relationships toolkit, and that came out in March. So we've managed to sneak it out in the pandemic. We weren't quite expecting that for our launch. But what that does is provide a lot of tools for staff to talk to people who are homeless about their relationships, and that includes their sexual relationships. And we're hoping that will help with conversations around sexual health and contraception, but also those broader conversations around, women's health, menstruation, sanitary products, because it just sort of breaks down that layer of stigma that staff feel, I think. So we're not perfect, but there are initiatives out there and we're getting there with it, I think.
Okay, that's great. And the next question is from Marianne from University of Bristol. Why do you think historically there has been more of a focus on homeless women who are male?
I think that's a good question. I think the answer to that is probably because men's homelessness is more visible. And I think regardless of any concerns we might have about women being homeless, it is true to say that more men sleep rough than women do. And I think in many people's heads and in public policy terms, rough sleeping has been the way in which people see homelessness, and that's the story that's told. So that the stereotypical view of a homeless person does tend to be a kind of man in his 50s, wearing lots of layers. He might be begging. It's a very kind of ingrained cultural image that we have of a homeless person that women don't tend to kind of feature in. But I think having said that, we've got such a better understanding now of the varieties of different types of homelessness and the hidden homelessness, as I said, that we do understand that it affects many, many women. So we're starting to kind of use research and campaigning to uncover the true picture for women. But I think it's the fact that people see rough sleeping as all of homelessness and men are more visible on the street. That'll probably be the driver for why men have been more prioritised, I guess, in homelessness services in the past.
Okay, thank you for that. Our next question is from Shamia. How do St Mungo's help homeless women with gynecological conditions, such as suspected cancer or incontinence or heavy menstrual bleeding?
Good question, yes. So we have, as well as our women's strategy, we have a health strategy as well. And we do, we're supporting our clients with a wide range of health problems. I wouldn't say that we have anything specific on those issues in particular, We are trying to expand our access, support our clients to access screening, so things like cervical screening, just sort of age-related screening that women should be having. But we're at early stages with that, so I think we've got more work to do on that. I suppose just to say that in general terms, we'd always be looking to support women and all our clients to attend house appointments. So a support worker might be available to go to an appointment with someone if they're very anxious about it, if they struggle with public transport, for example. And we'll always help clients to understand any kind of letters they're receiving, appointments. Quite a lot of our clients have literacy and numeracy problems, so it's actually even understanding, I guess, the information they're receiving about their health is something that someone goes to support them with, and that does take, that's quite a lot of what our support workers do. So nothing specific, but in general terms, we support all our clients to understand the communication they're receiving about their health and to attend appointments when they need to.
And I think our next two questions sort of tie in together. Are there any contraception available at hostels or information to people about contraception? And do you have services relating to promotion of safe sex and access to contraception?
Yes, so quite a number of our hostels will have condoms available. I think, as I mentioned before, if we're being honest and quite self-reflective about this, a number of our staff don't feel particularly comfortable discussing this kind of thing with clients. But yeah, there absolutely is contraception available, and particularly in our women's services, where quite a number of women may be involved in selling sex, for example, and where we have couples in projects that are living, in the same project, and we know someone's got a partner who's living elsewhere, staff will be proactive in asking about contraceptive needs. But yeah, we've got a long way to go on that as a sector. So yeah, I think that's on my list for next year for the women's strategy.
That's great. And the next question is from Pri. Given your experience, what specific areas of research are lacking into women homelessness in the UK?
There's a lot. I think my number one priority is probably research into the different types of violence against women that women are experiencing while they're homeless. There's a bit of a body of research around domestic abuse specifically, and the connection between domestic abuse and women's homelessness is quite well proven, both in terms of it being a driver of women's homelessness, but also experience while they're on the street. But I think what we tend to see anecdotally and kind of through operational experience is that women are not just experiencing violence and abuse from their partner, it's a broader range of exploitation, violence, abuse on the street that comes from different perpetrators. There could be members of the public, other homeless people, sometimes the police. I think we need to do a lot more digging and understanding into the dynamics involved in those kind of incidents of violence against women, because without that, it's really difficult to design good services to address that. And the traditional domestic abuse and violence against women sector, I think sometimes struggles to work with our client group because the presentation isn't quite typical. It's not necessarily someone who's living with their partner and then domestic abuse has occurred and they're leaving. They're kind of on the street. There's all sorts of people involved. There might be sexual violence, exploitation, begging, selling sex, all kind of mixed up in very challenging dynamics. So yes, my priority for the next year is to do some really deep qualitative research, to speak to women directly who've slept rough, to really understand the types of violence and abuse they're facing and also how they keep themselves safe. Because I think one thing I will say about our clients is they're extremely creative and very resilient people, and find ways to keep themselves safer that we as services might not agree with and might not think is good ideas, but they've worked, they're still alive, and that is a huge credit to our clients that they've survived such incredible hardship and danger. And so I think we as services have a lot to learn through research about the methods clients use to keep themselves safe and the advice they give to other clients in a similar situation. So yeah, that's my research priority for next year.
Great. And the next question is, do you find sexually transmitted infection rates are high amongst homeless women? Yes,
we don't have good data on this, but anecdotally, yeah, particularly among women who are selling sex, which isn't all women. I think the challenge with talking about that issue in particular is that there's a huge amount of stigma around women rough sleeping and the assumption that every woman rough sleeping is selling sex, and that's not the case. And women feel a lot of stigma around that issue, so I have to be a bit careful how I speak about it. But it is true to say that a fair number of our clients are involved either in selling sex in a more traditional way or in transactional arrangements. So they may be exchanging sex for drugs or sex for shelter, sort of survival sex situations. And then the risk of sexually transmitted diseases is very high. And women's access to care for those is quite poor, particularly if they've been, as I said, subject to sexual violence and may have a lot of anxiety around attending medical appointments. So, yeah, I haven't got firm data on it, but from our experience, I'd say, yes, it's a huge problem.
And the next question is from Ellie. How have St Mungo's services been affected by the COVID-19 pandemic, and what knock-on effects do you expect this to have?
It's been pretty fundamental. It's really fundamentally changed how we operate in a lot of ways, in a very short space of time, in the grand scheme of things. So I mentioned that thousands of people have come into hotel accommodation over during the first 2 weeks of lockdown. Thousands of people came into travel lodges, holiday inns, and we've had to adapt the way we work to work with very large hotel buildings. So it could be 70 to 100 beds. People we don't know very well, people who are new to services, haven't engaged before, or maybe they've been sleeping rough for a long time and now they've been afraid of COVID and have come inside for the first time. So it's been a real adjustment in that way. I think in the longer term, what it will mean is that we're unlikely to go back to providing services in shared spaces in the same way. I think the traditional homelessness shelter or assessment centre service might be that you're sleeping in a shared room. So the first step off the street quite often for people is some kind of shared accommodation where it might just be that you get a space to sleep or there's beds, in a shared room. And that was only ever for a few nights, maximum of a few weeks if you've got very complicated immigration status. But I think we're now reflecting and thinking that's not something we can really go back to following a pandemic like this. The rate of infection is just too high, and we've obviously had to close and decant all those services as a result of the pandemic. So at the moment, we're going through a bit of a reflection period about how we might run those emergency first step off the street type services in a different way that doesn't involve clients being together in a room for long periods of time, because that just doesn't seem sensible or safe. But I think also it is an opportunity to lobby for government for better homelessness service provision. We now know much more about a whole group of people who are on the street before the pandemic hit that are now inside and staying with us, and we're able to assess them and understand what their support needs might be. And then we can then present that back to government and say, we know about these people, you almost can't look away now. They've made the effort to get them inside. So it is this opportunity to really expand the provision that's out there to make sure no one has to go back to the street. And that could be brilliant, or it could be absolutely chaotic, and we'll have to see. I think we're still waiting for confirmation on what that might look like, those next steps. But we're hopeful, I think, still that it could be an amazing opportunity for thousands of people to leave homelessness behind. That's our best hope.
And our next question is from Molly. As well as women facing homelessness, are there any specific issues we should be aware of for pregnant women who are current sex workers? Or are there any other services? Yeah,
that's not my area of expertise at all. There are a number of services you might want to talk to. Maybe I can put together a list of services and perhaps share it with the organisers. There's a service in London that we work with a lot called Women at the Well, who are based in King's Cross, who work with women selling sex. It's a drop-in centre. They do outreach with street sex workers. And I'm sure they will have supported pregnant women selling sex, but it's not something we see often enough to really give general advice on. So I'd suggest contacting a service like Women at the Well, or if it's helpful, I can look and see if there's some other services I can point you towards. But yeah, I wouldn't want to give advice I'm not informed to give, unfortunately.
Okay. I'm sure our listeners will find those additional resources very helpful. Thank you. Moving on to our next question from Vicky, which I think you sort of answered in one of your previous answers, but do you expect to see a rise in the number of women who need support from St Mungo's due to the current pandemic?
Yes, we were expecting that early on, because we feared that the number of women who are hidden homeless, so they might be staying with friends or family, or with casual partners, or even strangers sometimes. We were expecting there might be a wave of women's homelessness as those women, when people are self-isolating, maybe someone in the household gets ill, that person has to leave and may end up rough sleeping or homeless, otherwise homeless. That hasn't necessarily happened in the way we thought it might, and I don't know whether that's because people are remaining hidden homeless just in very unsafe situations during the pandemic. It's a bit early to tell, to be honest, but I think in general, any kind of long-term impacts of the pandemic, like a recession, those things, and any changes to the welfare system, those things tend to hit women hardest. So we are likely, I think, to see more women struggling with poverty, destitution, and homelessness in future years as a result of this, just because most major shocks or crises in public policy do tend to have a disproportionate impact on women. But at the moment, we haven't seen the spike in women's homelessness that we feared we might, which is good news. So yeah, we'll have to wait and see how that develops over time.
Okay. Well, Catherine, I'm just looking at the time. There's quite a few more questions actually that people have asked you, but I think we might need to wrap up there due to timing. But thank you so much again for speaking at our conference, and I think it's given us all some valuable insight and information that we can use as healthcare professionals. So thank you very much again.
Thanks for having me. It's been a pleasure. Yeah, and if you want any more information, the organisers have my email address, so feel free to put anyone in touch with me if they want any more information.
Okay, yeah, that would be great. Thank you very much.
Thanks.
Okay, well, we'll now take a short break and we'll then have Katrina, who will introduce our next speaker.